Thank you for the introduction. I'm very pleased today that I will have the opportunity to present the findings, conclusions, and recommendations of this evaluation of PEPFAR on behalf of our consensus committee. This was quite an extensive body of work over the 4 years, as you heard, and it's very nice now to have the opportunity to discuss it with the stakeholders in this field and to have the public involvement today. So what I'd like to do is go over the evaluation. You heard from Dr. Salerno some of this background. I'll just make a few points here as we go. One is that the initial 5 years, the 5 years beginning in 2003, one might think of as the emergency phase of PEPFAR. There was a attention to very rapid scale up of the treatment, care, and prevention with very ambitious goals, as was said. The next 5 years, which were in some ways even more ambitious, but also had a different intention, and that is to focus more on the transition of activities and goals to contribute to a sustainable response in the partner countries. And we're now at the end of this 5-year period, and that's in part what the committee was able to take a look at. What we were evaluating was the entirety of the PEPFAR initiative. This was implemented in countries for this decade, with the largest share of the investment being currently in 33 partner countries. But the U.S. bilateral investment was even wider than that, involving about 100 countries. I'm seemingly not able to move this. Is it? Okay, if you can do that, thank you.
Well, we're sorting that out. Here.
Let me go on then as we go. You also heard that the Congress, in its authorization for this 5 years, mandate the Institute of Medicine to conduct the evaluation that has just been completed. It also set out rather detailed terms of reference for the evaluation, including assessment of the progress of PEPFAR's prevention, care, and treatment targets, progress toward these targets, and overall the impact of PEPFAR on these areas. It also had some specific aspects related to child mortality, child health and welfare, the efforts as they were implemented in regard to addressing gender-specific aspects of HIV/AIDS, and the effects of PEPFAR on health systems. Let's see if this, that worked that time. Good. And you also heard from Dr. Salerno about the Institute of Medicine. I won't repeat that. I would say that this was a committee with tremendous expertise, and this is the membership of the committee, 20 members in all, including myself, a very diverse, multidisciplinary group, and very experienced in the work, but as she said, without conflicts of interest, a very important aspect. So describe a bit about the evaluation approach and methods, and then get into the conclusions and recommendations. This was conducted over 4 years with a very extensive planning phase. There were actually 2 committees. The first one was the planning committee to establish the plans for the evaluation, and then a subsequent committee for the implementation of those plans. There was tremendous overlap, good overlap, about 3/4 of the membership overlap, but we did have some new members come in for the second phase. There was an attempt to look at the the HIV response in partner countries and globally since the inception of PEPFAR, so going back actually to 2003, although of course the more recent events, I think the more recent activities and accomplishments certainly were the focus. This was a whole of PEPFAR assessment, not an evaluation of specific countries, programs, partners, or agencies. So we learned a lot from our visits to countries, but we did not do an evaluation of the specific activities in those countries or provide feedback to the countries or the partners or agencies in the countries. This was also, as you can imagine, an evaluation that was made interesting, if not difficult perhaps, by the changing nature of the PEPFAR initiative. I think this is a very dynamic initiative that certainly did not stand still for our evaluation, and with the changes over the particularly the last several years in the activities, we had to try to keep up with that and be current as much as we could. It was decided in the initial planning phase that we would take what would be called a mixed methods approach, drawing on a wide range of data sources. This includes financial data that was available on the initiative. It included program monitoring data that was available to us, and particularly that the information that was consistent across time. It included some clinical data from the what were called the Track 1.0 implementing partners. This is from the first phase and continued really through the second, but the mostly university partners or other organizations that received initial funds for implementation during the first phase, and some of those organizations have quite extensive clinical information. We were able to access some of that. We also looked at the epidemiologic data on national prevalence of HIV and coverage from UN AIDS. There was quite extensive document review of the PEPFAR activities. And the primary data collection included visits by committee members to 13 partner countries. All of the committee members went to at least one country, and some went to two. The staff went to many countries, accompanied all of the committee members on these visits. In total, there were almost 400 semi-structured interviews conducted. 68 of those interviews were conducted during site visits to organizations that were providing services in the partner countries. There were also interviews with U.S. government headquarters and global stakeholders. So I'd like to talk first about the response to our Congressional Charge. The first aspect would be progress in meeting the targets. The targets, I think, were ambitious to start with and kept changing as, in fact, the targets were met. They were increased. So I would say the current target is treatment of 6 million individuals. And the latest report that we had is that 5.1 million men, women, and children are receiving antiretroviral therapy. So this is, as I say, an ambitious target and on the way to being met as the target has been increased. The prevention target was perhaps a little more elusive to see how much had been accomplished. The target is prevention of 12 million new infections, but we did not have available results of modeling of infections averted. It would have to be done by modeling because there's no direct way to measure that. But there is one aspect where the prevention has been quite successful, and that is the support of antiretrovirals for the prevention of maternal-to-child transmission of HIV, with nearly 750,000 HIV-positive women receiving antiretrovirals, with an estimate that more than 200,000 infants were therefore born HIV-free who might otherwise have been infected. In regard to care, the current target is to provide care to more than 12 million individuals, including 5 million orphans or vulnerable children. The latest results, PEPFAR indicates that it has directly supported the care of nearly 15 million people, including more than 4.5 million orphans and vulnerable children. I think we can say generally that the impact of the PEPFAR-supported programs would be very positive, with this support of HIV prevention, care, and treatment services, and the insurance of attention to vulnerable populations in HIV response. There's no doubt that this initiative has saved and improved the lives of millions of people. I think we'd also say that this initiative has provided a very important proof of principle that the services, in fact, in some ways complex services, can be effectively delivered on a large scale in countries with a high disease burden, with resource constraints, and with limited infrastructure. In regard to the effect on child health and welfare, the initiative has tried to meet the needs of children affected by the epidemic. There has been really unprecedented attention to and investment in the orphans and vulnerable children programs. We would also say that the coverage of care and treatment for HIV-infected children perhaps is lagging the coverage for adults. Less ability to identify those who are infected and need treatment, and this is an area that we think needs further focus. The efforts to address gender-specific aspects, although evident in some ways, with regard to both women and girls and men or boys, but we thought there was a need to clarify the objectives and to specify better the desired outcomes of these gender-specific efforts. We, as part of the Congressional Charge, looked at the effects of PEPFAR on health systems, and in this case, used the 6 WHO building blocks as components of health systems, as illustrated here in the figure. It was very clear that there were major contributions of PEPFAR in laboratory strengthening, in supply chain management, in training and support of the workforce, and in policies in countries related to the HIV response. Was also examples of increased knowledge about the epidemic and response, particularly in support of the collection of epidemiologic data through periodic surveys and through other means, and also in strengthening, working with partner countries to strengthen the health information systems that could be used for this and other purposes. We were very interested in, and certainly in our discussions with OGAC, asked very much to comment on the efforts in regard to the transition to a sustainable response. We looked at the efforts in capacity building, and particularly in fostering country leadership. And I think it is very clear that the initiative is moving in this direction, increasingly with joint planning with governments and other stakeholders, transitioning to a more country-led and sustainable response. But we know, as I'm sure PEPFAR does, that this will take time. Not every country is ready to take on the responsibility, and this will be, in some countries, perhaps a long transition to full country ownership and responsibility. There is, of course, a very high reliance on external donor funding in partner countries, either from PEPFAR or the Global Fund. And in our evaluation, we purposely selected countries that had predominantly PEPFAR or Global Fund, or both, a mixture of both, to assess. But I think, in short, there's still a lot of fragility in regard to the funding situation because of the limited number of funders. In regard to knowledge management, this was not a specifically mandated charge by Congress, but we thought it was a very important element of the initiative because it cut across so many areas and certainly influenced and affected very much our ability to to provide a thorough and thoughtful evaluation. So we have a number of conclusions and recommendations in regard to knowledge management. From the beginning, PEPFAR developed systems for accountability through program monitoring. And over time, I would say, has improved the support for program evaluation and research. I mean, the evaluation and research area, I would say, has not been a strength of the initiative, although there have been recent improvements in this. The initiative also very clearly used evidence to inform programs and responded to emerging knowledge and scientific evidence. I think it's certainly to be commended for this, that as soon as evidence has become available on new interventions, particularly impressively the biological prevention areas of male circumcision or treatment as prevention, these have been very much embraced and implementation begun. There is also, though, not as much contribution as one might hope to the global knowledge base on effective HIV/AIDS programs and program implementation science, and particularly in regard to the behavioral prevention areas that are still somewhat problematic as far as us understanding how effective they are and how they can be best implemented. A little more specifics on the knowledge management. I would say that initially the specific data collection systems were designed to meet the needs for reporting on the targets, particularly on the delivery of services. So, if you will, the numerators that were part of the targets, how many to be on treatment, how many to receive care. But initially there was limited harmonization with partner countries and the global community. More recently, OGAC has worked to improve harmonization, but we still think more progress is needed. There is a large burden of reporting requirements. We heard that in many of the countries we visited. And this burden of reporting requirements is not uniformly believed to have been very useful for determining the success of programs. And in particular, the system does not allow assessment of outcomes of services, and I'll say more in a moment about that, or effectiveness of the programs. And it doesn't, at this point, or at the point we looked at it, in any case, in the evaluation, captures some of the key activities that are rather critical for the future as the initiative transitions to a role of supporting countries in their efforts to control HIV/AIDS, such as technical assistance or efforts for capacity building or efforts for system strengthening. These are all areas where the program monitoring needs to be able to capture the contribution of PEPFAR. So I would say our overall conclusions are that PEPFAR has had very positive effects on the health and well-being of beneficiaries as individuals, also on institutions and systems in partner countries, and of course on the global response. Even with this remarkable contribution, there is substantial unmet need, and this remains for all services and programs that are necessary to treat and contain HIV. An important issue for the future is to sustain these gains and to make progress while still engaging in this necessary effort to work with partner countries to have them manage their epidemics and take further national responsibility. So we made recommendations in these 4 areas: improving implementation of HIV programs, strengthening systems and capacity for response in partner countries, transitioning to a sustainable response, and transforming knowledge management. And I would say generally PEPFAR is definitely moving in a direction consonant with these recommendations. And our intention in the evaluation is to inform, support, and improve further progress. And so we're trying to provide additional insights and thoughts as as a basis for moving forward to improve these country programs and the U.S. government response. So for just some brief highlights of the recommendations, as I said, the movement now is to collaboration with partner country stakeholders, and this includes the allocation of limited resources in ways that are strategic, targeted, and coordinated. And they also reflect, as has been the case, but increasingly will also have to encompass the epidemiology in these countries and the circumstances and needs of each country. We thought there could be improved efforts and good opportunity with better linkages among services, such as those within the HIV realm, HIV counseling testing to care and treatment and prevention, but also HIV/AIDS with other, particularly maternal child health services, but also other health services. There has been, and I think admirably so, a focus on vulnerable populations, but with the transition to country leadership, there will have to be continued dialogue about this to be sure that those at high risk will still receive services that are needed. And we thought, as I mentioned before, that the efforts in regard to sexual transmission is really the key, the crux of the control of HIV transmission. And while we had good experience and implementation of some of the more biomedical interventions, there is maybe less emphasis or less learning that we might wish in regard to the behavioral interventions, and these will increasingly be important for control. For another aspect of the way the initiative is managed, I would say that we're recommending a shift of the focus from activity monitoring to prioritizing outcomes, and then having the discussion within countries of how to best achieve those. And just some examples of this so you know what I mean by the difference between activities and outcomes. This could include more efforts to improve retention and adherence to those who are in care and treatment. It would certainly include more attention to coverage of testing and treatment. So by coverage, I mean those who need the service are receiving it. So as I mentioned, much of the monitoring has been in regard to the numerator. Increasing coverage or monitoring coverage would mean we have to know the denominator, how many need treatment, and how well is this initiative, or in fact are the countries meeting that need. It could include increasing rates of staying in school, for example, and a number of other aspects that I think will go on then and not itemized for the sake of time. In regard to building this long-term capacity to achieve the sustainable response that I think we all want, there are 4 areas where we thought there could be even greater investment. Certainly the service delivery has had very strong support from PEPFAR, but with the transition, this would need to be taken on more by partner governments and non-governmental organizations, with their responsibility being devolved more to country level. And 3 areas of management that seemed not strong enough in many countries to really support the country responsibility that's needed. Financial program and knowledge management all are areas where we thought additional capacity building could be worthwhile and in fact necessary. So planning with the partner country stakeholders, I know very well, and many of you are in the audience, has been going on, and there are a number of aspects of this that that we identified. I don't think any of these are truly new to those who are involved in this process, but for the sake of completeness, we wanted to state that these are all critical elements in the country-specific planning that has to go on and in fact is being done. For a recommendation on program monitoring, evaluation, and research, we thought there was still a need to develop reliable, credible approaches to assess the outcomes. I gave some examples of this for services and programs, to assess the aspects of system strengthening, capacity building, and supporting sustainability. We thought there was a need to document the contribution of the improved performance and effectiveness of national efforts. Over time, it will not be possible to directly attribute, in fact, it hasn't been literally possible to directly attribute even now the particular activities to PEPFAR support, but over time with more national ownership, this will become even more difficult, but yet there is still a need to document the contribution that the U.S. government support through PEPFAR or its successor initiative to the country activities. And we thought there was a need to contribute, in fact, more to the global knowledge base through dissemination of knowledge on effective implementation of the programs that are supported. Final conclusions, I would say that it is quite clear that PEPFAR has played a very transformative role in its contribution to the global response. It has been described in many ways as a lifeline, and people in countries as well as the global stakeholders credit PEPFAR for restoring hope in a situation with a terrible disease. It is also very clear, as is being done by PEPFAR, that there is a need to transition from direct service delivery to more technical assistance, more support for local implementation, more focus on facilitation of the partner country leadership, and meaningful engagement of other partner country stakeholders. It is possible that this era will see results that will not be as dramatic and with rapid gains as in the past, but hopefully we will not go backwards, and possibly the new paradigm of working with partner countries will in fact improve and enhance and increase the services. And in fact, there is the potential to transform the way health assistance is envisioned and implemented for this epidemic. I'd like to acknowledge as well, as Dr. Salerno did, the excellent staff and consultants that we had to work with, Kimberly Scott and Bridget Kelly as the study co-directors, but the entire staff that are listed here and the consultants that helped us with both the quantitative and quantitative analyses. So I will say this report would not have been done and completed without them. So I do thank them. And I think that's all I have on this one. Thank you.